The topic we have selected for the inaugural lecture is Approach to Fever in Current Practice. To talk on this topic, we have invited a very special resource person who is the senior physician at the National Institute of Infectious Diseases, Sri Lanka. He has his expertise in the management of dengue, SARS, avian flu, and other emerging infections, and also HIV. He has contributed immensely in the developing of WHO and national guidelines in dengue management and was leading in the front line in COVID management in Sri Lanka. He has won the ProMed Award for Emerging Infectious Diseases in 2016 and President's Award for Scientific Researchers in 2016, 17, and 18. Further, he was the president of the Ceylon College of Physicians for the year 2020 and is the SLMA president-elect for 2024. He is none other than Dr. Ananda Wijewickrama.
Good morning. First, I would like to thank the GMOA for organizing this event. As all of us know, continuous professional development is a very important aspect in our career, in our profession. And as a professional organization, it is very important to address this issue. And as GMOA, acting both as a trade union and as a professional organization, it is very welcome to take up this program. And I would like to thank the GMOA for asking me to do a presentation as the inauguration of this, program. Since I am working in the infectious diseases hospital, naturally my topic would be related to infections. So I thought of talking to you on approaching to a patient with fever in primary care setup. As we know, this is a common problem. In being a tropical country in Sri Lanka, fever is one of the commonest presentation we see in our day-to-day practice. It's just, as we all know, it's a symptom, and the commonest cause of this symptom is an infection. And for that matter, acute fevers are mostly due to an infection. However, in case of prolonged fever, it could be due to infections or could be due to other causes. Especially, we have to consider here, I would like to mention at the beginning itself about tuberculosis, because it's a common problem which we have to detect in our country. So when would you suspect an infection in a patient who is presenting with fever? Before addressing that, what is an infection? This is defined in Cambridge Dictionary as a disease in a part of your body that is caused by a bacteria or a virus. And there's another definition, and that says an act of passing harmful programs into a computer or file, or the harmful programs themselves. But the medical definition is more strict, and that says the invasion and multiplication of microorganisms such as bacteria, viruses, and parasites that are not normally present in one's body. So when would you suspect an infection? As we have already mentioned, the commonest symptom of an infection is fever. But infection may not cause symptoms. Sometimes it can be subclinical or may cause symptoms or can be clinically apparent. And of course, the symptoms depend on the microorganisms and the site, and some of the symptoms are common. And in addition to fever, depending on the organism and the site, the patients can have features like diarrhea, dysuria, localized painful swelling, weight loss, cough, etc., etc. Let's look at this patient. This is an actual patient I came across a couple of years ago. Still, I remember this patient because that taught me an important lesson. This is a 17-year-old girl presented with fever and sore throat for 2 days duration. She also had mild headache and body aches. A quick examination done by the physician at that time has not revealed any abnormal physical findings except for the mildly inflamed throat. Now, if you get this patient to your practice, what investigation you would do? Would you do no investigations, a full blood count, ESR, CRP, dengue antigen, dengue antibodies, SOT, what? Just think for a while. Would you start her on antibiotics? What antibiotics in that case? Amoxicillin, coamoxiclav, cefuroxime, clarithromycin, azithromycin, any of the above, or none of the above. What would you do? Think for yourself. Now, what is the most likely etiology of fever in this patient? Could it be a streptococcus pneumoniae, other bacterial infection, viral infection, influenza, fungal? What? Because our decision to do investigations and to start the patient on medicines, pharmacological treatment will depend on this etiology. Of course, we would give some treatment for symptomatic improvement, but the definitive treatment, for example, antibiotics or antivirals, will depend on the possible likely etiology. Now, this is a study done at North Colombo Teaching Hospital a couple of years ago, where they analyzed 617 patients out of 711 febrile patients admitted to medical wards. Now, here there was confirmatory diagnosis in little more than half of them, and of these 38% were viral. And then there were other things like leptospirosis, various bacteremia, rickettsial infection, tuberculosis, and so on. And then, in addition, in these 617 patients, 37.2% had unconfirmed diseases, including viral fever, undifferentiated fever, and so on. So when you look at these figures, this is a good study done after a lot of investigations. If you look at these figures, you realize that more than half of these patients had viral infections. Now, these are the patients who are admitted. Now, the percentage of patients coming to your general practice or to OPD would be, in that the viral infections would be much higher than this. So, mostly those are viral infections. Now, we'll go back to this patient. So, this patient, the doctor who saw that patient at that time started the patient on coamoxiclav. But you'd agree with me, the most likely cause for her fever and sore throat is a viral infection. So let's see what happened. So then why do we start these patients on antibiotics? There can be many reasons. These are some of the reasons I could think of. If it is viral, it is viral, we know, but then there's a possibility of bacterial infection also. And even if it is viral, it is safe to give antibiotics. And sometimes some people might say, no, it is a bacterial infection. And then sometimes the patient might need antibiotics little later, so the patient might have to come back later. So why not give antibiotics now itself? So there can be many reasons like this. And then there may be some patients, some doctors who would start the patient on antibiotics to make the patient happy. And also they might wonder, if antibiotics are not started, patient might go to another doctor. And I would like to mention this point here. We have seen some patients starting ciprofloxacin for this sort of infections, and without any hesitation, but this is a big problem. One thing is, ciprofloxacin is not an effective antibiotic for common respiratory pathogens, and also, more importantly, it is used as a second-line treatment for tuberculosis. So by giving it freely for unnecessary or unwarranted conditions, you will make tuberculosis more resistant to ciprofloxacin. So we are losing the second-line anti-tuberculous drug. And in addition, fluoroquinolines, ciprofloxacin is one, can cause serious and disabling side effects. So therefore, it has to be started in patients when it is really necessary. And in addition, these things can cause antimicrobial resistance, unnecessary starting or use of antibiotics. Now, the penicillin, the first commercialized antibiotics discovered by Alexander Fleming make him getting the Nobel Prize. And when he accepted the Nobel Prize, he warned the world of bacteria becoming resistant to penicillin in his acceptance speech. And now we see that it has become a reality. Should we worry about antimicrobial resistance? If you take United States, at least 2 million people become infected with bacteria that are resistant to antibiotics. And at least 23,000 people die each year as a direct result of these infections. We don't have our figures, but I'm sure it must be pretty high. There are urgent threats also: Clostridium difficile, carbapenem-resistant antibacteria, and drug-resistant Neisseria gonorrhea. We also have these things. And then there are others, multi-drug-resistant Acinetobacter, Campylobacter. We see a lot of these patients, a lot of these bacteria are detected in our hospital patients. But then can anything happen to my patient? This patient was given coamoxicillin. Right? But we know often these infections are viral and some get secondary bacterial infections. Giving antibiotics at the viral stage leads to secondary infections with resistant organisms. And in our day-to-day practice, culturing can be difficult, and then patients can have bacteremia with multi-drug resistant organisms. So this girl's fever continued. Then the antibiotics were changed after a few days. It was changed again. Still the fever was continuing and no focus was found. And then this patient's mother's sister was a consultant radiologist. She was not working in Colombo, she was working in out of Colombo. But one day when she came to see the patient, then she said, now this patient is having a viral regurgitation. Then only it was looked at and she was found to have a bacterial endocarditis. And she was very ill, she was almost dying. And at one time surgery was contemplated to remove the vegetation, but then the surgeon said she was too ill to have surgery. Fortunately, finally she responded to vancomycin. So she had a narrow shave. All this because of the antibiotics she was started on for viral sore throat. So we know, as we discussed, most of these are viral: flu, dengue, upper respiratory, lower respiratory tract, hepatitis. And then the bacterial things also can cause lower respiratory, upper respiratory. These are the common ones, and we cannot forget tuberculosis because it's common and important infection in Sri Lanka. And then leptospirosis, another common infection in Sri Lanka. Meningitis and bacterial endocarditis, though they are not common, those are important causes which can lead to death of patients unless we suspect and detect it early. So therefore, you have to think of this list of possible infections in any patients who comes to you. So what investigations you can do? Of course, it depends on the duration of the illness and the symptomatology of the patient, showing the possible site of infection. But generally speaking, full blood count and CRP are quite often useful in investigations, especially the full blood count. Depending on the patient's symptoms and possible suspected focus of infection, we can do urine full report, chest X-ray, and then the blood picture can be useful at times. It will differentiate the viral from bacterial at times, and also the CRP. And then depending on the symptomatology and the possible focus, sputum, urine and blood cultures as appropriately should be done. In a patient who comes with fever for more than 2-3 weeks, or especially with cough going on for more than 2-3 weeks, it is important to look for tuberculosis. And in such cases, sputum AFB, repeated samples is important. And liver function test, echo, ultrasound could be done appropriately, not in all the patients. But in most of these patients, the full blood count will be useful. If there's any suspicion, do a lumbar puncture in the hospital setup to see whether it is sort of meningitis or meningoencephalitis. Then in other hospital cases, the lymph node biopsy, fine needle aspiration, then certain antigens, prolonged fever, antibodies, and of course you should not forget drug fever in the patients coming with prolonged fever. And then we do various antigens in patients in dengue, in rapid antigen for influenza, COVID. But if you're doing antigen, do it early. Antigens are detectable generally within first 2 to 3 days of an illness. Not the longer the duration, the detection rate get less. And similarly, if you are doing antibodies, do it later in the course of the illness. Do it around 6-7 days of the illness. No, there's no use of doing antibodies at the beginning of the illness because antibodies have not formed. However, in dengue, if you're doing antigen, do it within first 2 to 3 days, but you have to remember the sensitivity is not 100%. It is around 70 or even less than that. Therefore, while positive antigen in the setting of Sri Lanka virtually confirms dengue infection, a negative result does not exclude dengue infection. So therefore, if you are doing antigen, tell the patient, even if it is negative, that still it could be dengue. Therefore, following up these patients with repeated full blood counts is important. And if you're doing antigen, again, do it after 6 days. However, if it is a secondary infection, IgG can be positive in the early part of the infection. Talking about SAT, this is an infection which we have been doing commonly when we were junior medical officers and registrars, but now it is not commonly done because the sensitivity of this is not very great. And however, if the O antibody titer is more than 1 in 120, then you can reasonably suspect that. But having said that, we have to say that more than doing SAT, doing a blood culture without giving an antibiotics is important, and that may enable us to detect salmonella in these patients. And of course, even though it's not common, keep HIV in your mind, especially in a patient who comes with prolonged fever. This is another patient who came, an 18-year-old boy presenting to a private hospital with high fever for 2 days duration. He also had severe headaches, severe body aches and dry cough. There was no abnormal physical signs. Count was done, white count was 7,200, neutrophils 70%, platelet 210,000, dengue antigen was negative. What did you do for his high fever and body aches? Would you give only paracetamol, or would you give diclofenac, mefenamic, or ibuprofen, or celecoxib? What would be your choice? In this case, the patient was given ibuprofen. And next morning, he developed melena. He was alone at his home. Parents have gone for work. He was studying for A-levels, and a few hours later, he collapsed. He was brought to a hospital, tertiary care hospital. He was in profound shock. So in spite of giving the best possible care at the tertiary care hospital, he died. They couldn't stop bleeding. After many transfusions, he died. So this is what can happen when, subsequently he was positive for dengue. This is what can happen when NSAIDs are given to fever patients in case if it is dengue. Now, since antigen test can be negative in some of these dengue patients, even if it is negative, please do not use NSAIDs for fever patients. Especially now our country has become endemic for dengue. So any patient can be a dengue patient any patient coming with fever can be having dengue. So therefore, please do not use NSAIDs. Unfortunately, still these being used. This one of our patients who came to our hospital who had treatment from a private place. These are some other prescriptions and packets from private hospitals. And this is another, recently, I took this photo just 3 days ago. You can see this patient had gone with fever, body aches, headache, and to a private hospital. And he was given 1, 2, 3, 4, 5, 6, 7, 8 drugs, including diclofenac sodium. So when the patient came to us, patient had dengue, and patient had complications. We had to give blood, and finally we were able to save the patient. But all these are unnecessary complications caused by medication. So how should we approach a patient who is coming to the primary care setup, to your general practice or to the OPD? Let's look at another patient. This patient a 30-year-old lady presenting with fever for 3 days, full blood count showed low white count, platelet was 190,000. She was given symptomatic treatment, including ibuprofen. This patient, I still remember this patient because later she came to my hospital. She was not feeling well, went back 2 days later, still feeling unwell. In fact, this patient's husband was working in MOH area, in the health staff, and the MOH himself treated this patient, and he gave her antibiotics. And in fact, they asked whether to do a blood test, and he was told not necessary. Next day, she was admitted to NHSL. Later, she was transferred to my hospital. She was in full-blown shock when she was admitted to NHSL. She was in prolonged shock, and she could not be resuscitated and died. So we see several problems in this patient. Firstly, in spite of having low white count, dengue was not suspected. Patient was given NSAIDs, and even later, when the patient went back to the doctor, in spite of the patient being not feeling well, the blood count was not done. Full blood count is a simple investigation, relatively a very low cost investigation. We give a lot of drugs which are expensive than full blood count. So please do a full blood count in a patient where it may not be necessary around first 2 days, but later if the fever continues, or if you suspect dengue, please do a full blood count and follow it up if necessary. This is important. And unfortunately, we see in some of these dengue patients who come late with complications, blood count had not been done in spite of they have gone to doctors. So please do that. That gives us a lot of information. A lot of things can be thought of and arrived. Many decisions can be arrived at with that simple investigation. So what you suspect will depend on the country in the sense the area, and also some of these patients have traveled to other countries, and of course their occupation, exposure, etc. And of course, while suspecting common infections, you have to also think of possible serious infections, because one thing, you can't miss those, and it is important to exclude those which can be done most of the time clinically, especially meningitis, endocarditis, and sepsis. So it is important to take a brief history, a quick examination, look for murmurs, neck stiffness, muscle tenderness. Right? So it's clinically you can exclude possible meningitis. If there's a suspicion, always send the patient to hospital, admit the patient. If the patient is very ill, if it is the patient's general appearance is not compatible with the duration of the illness or the symptoms, straight away don't hesitate to admit these patients. Because sometimes we see patients, especially old people, coming in sepsis within a short duration of illness. Their history will be short, 2-3 days fever, or feeling unwell for 2-3 days, and the fever for 1 day, and they're in sepsis. And they will go into septic shock in a matter of a short time. And most of these patients need only symptomatic treatment. And this is a patient who had a different history. She was from Tangol. She was first admitted to NHSL, to Karapiti Hospital, later to Jayawardenepura Hospital, and she gets admitted with the complaint of fever, and they found that she was febrile and she was discharged. And the mother insisted that the girl is having fever. And the patient, when I saw the patient looked well. But however, because the basic investigations were also normal. And the mother was pleading. In fact, I admitted this patient because of the plea of the mother because patient looked so well. So I was not sure whether it is necessary to admit. However, then I admitted, and I was thinking of possible endocarditis and things because of prolonged fever. So I did a blood culture, and she did not have fever. But next day, she had a fever spike. And then we kept her for another day. Then one of our doctors took a detailed history and then found 1 year ago she had been to India. Then we tested her for malaria and that was positive. So therefore, the travel history is very important. Even though it's not common, finding a case of malaria is very important because we have eliminated malaria. So all what we see at the moment are imported cases, and it is important to detect these patients because even though we have eliminated malaria, the vector is still there. So it is important to prevent spreading of such situations. So duration is important. If it is short duration, think of dengue. Also, it is important to realize that sore throat, dry cough, diarrhea, such symptoms do not exclude dengue. Some dengue patients have these symptoms. Therefore, think of that, and it is common. And at the moment, it is increasing, especially in the Western province. It is increasing, so always keep that in mind. And always also think of leptospirosis, another common illness in our country. And also, it is an illness where we have to suspect and detect early. Early treatment save these patients. Otherwise, they will have the complications like renal failure, pulmonary hemorrhage, and so on. And of course, nowadays we have influenza and COVID. So if the respiratory symptoms are there, think of those illnesses. And if the patient is having couple of weeks fever or couple of months fever, always think of TB. TB is common in Sri Lanka. Every year we detect around 9 to 10,000 new cases in Sri Lanka. So it's a common illness and it's a treatable illness. And also early treatment prevents the spread of the illness of TB. Therefore, it is important to detect these patients early. And then ask about the travel history, especially to India, to Africa, and to Papua New Guinea. In those countries is common, and our people go there for various things, for jobs, the gem mining, and so on. And the army personnel go for to work there. And also think of HIV, especially if the patients are having weight loss, anemia, and high ESR. If the patients are having high ESR, think of the possibility of anemia, of HIV. And then there are many other possibilities in a long-standing fever. Of course, we have to think of dengue, as I have been telling repeatedly, because it is common in Sri Lanka. Do a full blood count at the end of second day, at end of 48 hours, if may be normal or abnormal. If it is normal, it's worth repeating it 24 hours later. It will tell you whether it could be dengue or not, even if the antigen is negative. In dengue, CRP can be mildly elevated, maybe about around 25-30. And it's important, as I have been telling repeatedly, please do not give NSAIDs to these patients and do not give steroids, and they don't need the antibiotics. Think of leptospirosis. Sometimes it can be difficult to differentiate it from dengue. So if you think of the possibility of that, start patients on treatment, penicillin or ceftriaxone. Of course, they have to be admitted. And they will have high fever, myalgia, muscle tenderness, conjunctival suffusion. And if you do a full blood count, it will show white count to the high side with neutrophil leukocytosis. And bilirubin can be high. SGOT-PT will be only slightly elevated if at all. But sometimes if you can't differentiate it from dengue, start treatment as for dengue, but monitor as for start treatment as for leptospirosis, but monitor as for dengue. If you are thinking of influenza or COVID, it's not essential to confirm the diagnosis in the present context, but if necessary, we can do rapid antigen test. It's not essential. Full blood count CRP can be done and can be normal, CRP can be little high, and most of these patients need only symptomatic treatment. However, if you think of influenza, or think of starting oseltamivir in high-risk groups, especially in pregnant mothers. and do not give antibiotics initially. Maybe they will need antibiotics later, not initially. Maybe after 5-6 days, when they are getting possible secondary bacterial infections, they might get antibiotics. So the history, signs and symptoms, and full blood count are the three most important things in detecting the possible cause and treating these patients. Good history is very important, and a short, relevant, quick examination is essential. Full blood count is the single most important investigation, might need serial full blood counts. Other investigations can wait if in acute fevers. So we see bad practices, starting antibiotics early for any fever, giving NSAIDs, giving dexamethasone, prednisolone. Now, of course, some people use betamethasone also. Now, these indicate maybe lack of confidence, lack of knowledge, or maybe some people are going after money. So please do not follow these bad practices. It's a common, we know fever is a common symptom. We encounter that every day. It is important to approach this symptom rationally and treat our patients. Thank you.